Hi everyone, I am Mini Ryu, a medical oncologist in Asan Medical Center, Seoul, Korea. Dr. Wilson presented the treatment options in advanced esophagogastric cancer in the West and the East comprehensively. I'll more focus on the treatment options for metastatic gastric cancer in the East. Approved therapeutic agents for metastatic gastric cancer can be categorized into cytotoxic chemotherapeutic agents, immunotherapeutic agents, and molecular targeted agents. Cytotoxic chemotherapeutic agents include 5-FU and its oral derivatives, capecitabine and S1, paclitaxel, docetaxel, irinotecan, and TAS-102. Immunotherapeutic agents include pembrolizumab and nivolumab. Molecular targeted agents include anti-HER2 antibody, trastuzumab, anti-HER2 antibody drug conjugate, TDXD, trastuzumab, deruxtecan, and anti-angiogenic agents, ramucirumab and apatinib. Monotherapy or combination of these agents are used in diverse clinical settings of metastatic gastric cancer. First, let's look at the first-line chemotherapy. When a patient is diagnosed with metastatic gastric cancer, tests for HER2 should be conducted prior to first-line chemotherapy. HER2 is a kind of growth factor receptor which exists on cell membrane of cancer cells. HER2 is related with growth of cancer cells. First, immunohistochemistry is conducted to detect HER2 protein in cancer cells. If immunohistochemistry score is 3 positive, HER2 is defined as positive. If immunohistochemistry score is 2 positive, a test for HER2 gene amplification, FISH, is added. And if a FISH is positive, then HER2 is also finally defined as positive. HER2 is positive in about 15 to 20% of metastatic gastric cancer patients. First-line chemotherapy is determined by the HER2 status. This slide demonstrates HER2 immunohistochemistry stain scores from 0 to 3 positive. I'll talk about the first-line chemotherapy for HER2 negative metastatic gastric cancer first. Generally, treatment outcomes and adverse events are correlated with the number of cytotoxic chemotherapeutic agents. Response rates is usually 15 to 20% with monotherapy, 14% with 2 drugs, and 60% with 3 drugs. Adverse events also increase with more chemotherapeutic agents. Usually, 3-drug combination chemotherapies are too toxic, and treatment outcomes of monotherapy are not satisfactory. So, 2-drug combination chemotherapies are generally used as first-line treatment of metastatic gastric cancer. 2-drug combination of fluoropyrimidine and platinum is the standard of care as first-line cytotoxic chemotherapy in HER2 negative metastatic gastric cancer. There are 3 fluoropyrimidine agents, including 5-FU, capecitabine, and S1, and 2 platinum agents, including cisplatin and oxaliplatin. We can have 6 combinations of fluoropyrimidine and platinum. These 6 combinations show almost the same efficacy, but different toxicity profiles. Cisplatin is more toxic and inconvenient compared with oxaliplatin. So cisplatin is currently seldom used and has been replaced by oxaliplatin. Accordingly, 5-FU plus oxaliplatin combination, FOLFOX, capecitabine plus oxaliplatin combination, CAPOX, and S1 plus oxaliplatin combination SOX are the most commonly used regimens in daily practice. However, S1 shows ethnic difference in metabolism, so doses of S1 are different between the West and the East. For this reason, FOLFOX or CAPOX is used as a common backbone chemotherapy in global clinical trials, including the West and the East. FOLFIRI, a 5-FU and irinotecan combination, is an option for first-line chemotherapy in HER2-negative gastric cancer. It shows the same efficacy as FOLFOX or CAPOX and different toxicities. FOLFIRI is usually used in patients with recurrence after surgical resection of localized gastric cancer who were already exposed to adjuvant CAPOX. As Dr. Wilson already mentioned, 2 clinical trials demonstrated that nivolumab in combination with first-line chemotherapy is superior to chemotherapy alone. In the CheckMate 649 study, patients both in the West and in the East were enrolled in the study and got benefit regardless of regions according to the subgroup analysis. In the attraction for study, patients only in the East were enrolled. But this combination is not yet approved in the East Asian countries. I expect that this combination therapy will be also approved sooner or later in the East Asian countries. Let's move on to the first-line chemotherapy for HER2-positive metastatic gastric cancer. Trastuzumab in combination with cytotoxic chemotherapy improved the treatment outcomes in HER2-positive gastric cancer. The same regimen, including trastuzumab, is used in HER2-positive gastric cancer in the West and the East. Very recently, pembrolizumab plus trastuzumab in combination with the cytotoxic chemotherapy showed very promising results in HER2-positive gastric cancer. Dr. Ilsen already mentioned the results of the phase 2 study conducted in the Memorial Sloan Kettering Cancer Center. The Korean phase 2 study also demonstrated promising results with response rate 77% and the median progression-free survival 8.6 months. In the 2021 ASCO annual meeting, the results of interim analysis of the Keynote 811 phase 3 study were presented. Patients in the West and the East participated in the study. Response rate was 74% with pembrolizumab versus 52% with placebo. With these results, very recently, this combination treatment has been granted accelerated approval by the US FDA. But this is not yet approved in the East. Generally, regulatory authorities in the East Asian countries requested the final positive results of phase 3 studies for new drug approval. Let's move on to the second-line chemotherapy. The phase 3 studies conducted in the West and in the East demonstrated that second-line chemotherapy can also improve overall survival compared to the best supportive care. According to the phase 3 clinical trials before ramucirumab, paclitaxel, docetaxel, or irinotecan monotherapy induced the survival benefit. In the Rainbow and Regard phase 3 studies, patients both in the West and in the East were enrolled and got benefit regardless of regions according to the subgroup analysis. In the Rainbow study, ramucirumab plus paclitaxel was superior to paclitaxel alone. Based on the results of Rainbow study, ramucirumab plus paclitaxel has become the treatment of choice of second-line therapy. Finally, let's look at third or later-line chemotherapy. Several phase 3 studies demonstrated that third or later-line treatment can also improve overall survival in metastatic gastric cancer. A Korean phase 3 study showed that second or third line docetaxel or irinotecan can improve overall survival. A Chinese phase 3 study demonstrated that apatinib, an anti-angiogenic agent, can induce survival benefit. Although apatinib is not proven to be effective outside of China. The Attraction 2 study conducted in the East Asia demonstrated that nivolumab monotherapy is superior to the placebo. The TAGS trial, which enrolled patients both from the West and from the East, TAS 102, has been proven to be effective. A phase 2 study conducted in Japan and Korea has demonstrated that T-DXd trastuzumab deruxtecan induces marked survival benefit compared with the physician's choice of chemotherapy, paclitaxel or irinotecan, in third or later line setting in HER2 positive gastric cancer. Pembrolizumab showed promising outcomes in mismatch repair deficient MSI high cancers, including gastroesophageal cancer. In this slide, I summarize the standard of treatment, current or in the near future, in metastatic gastric cancer in the East. First, test for HER2 should be conducted. If HER2 is positive, trastuzumab in combination with capecitabine plus cisplatin or 5-FU plus cisplatin is the standard of care. If HER2 is negative, fluoropyrimidine plus platinum doublet is currently the standard of care. With the final results of the Keynote 811 study, pembrolizumab will be approved in HER2 positive gastric cancer, even in the East. In the near future, nivolumab will be added to the first-line chemotherapy in HER2 negative gastric cancer after approval by the regulatory authorities in the East. Paclitaxel plus ramucirumab is the treatment of choice of second-line treatment. If paclitaxel plus ramucirumab combination is not tolerable, then taxane, irinotecan, or ramucirumab monotherapy can be used. Pembrolizumab is the treatment of choice in MSI high gastric cancer after failure of first-line chemotherapy. In HER2 positive gastric cancer, T-DXd trastuzumab deruxtecan is the treatment of choice of third-line treatment. T-DXd is currently approved only in Japan among the East Asian countries. Other third or later line treatment options include nivolumab, TAS 102, irinotecan, or taxane. Apatinib is proven to be effective and used only in China. There are ethnic differences in chemotherapeutic agents in metastatic gastric cancer in the West and the East. Regarding S1, slow metabolizers are more common in the West. Accordingly, S1 should be used at a lower dose in the West. S1 is currently rarely used in the West, although it is very commonly used in the East. With the docetaxel, patients in the East Asian countries show myelotoxicity more commonly, so docetaxel has been used at a lower dose in the East and currently rarely used in the East. The efficacy and tolerability of other chemotherapeutic agents, immunotherapy, and targeted agents are not so different between the West and the East. Major clinical trials in metastatic gastric cancer are already mentioned by Dr. Ilsen. I don't want to repeat them again. I just want to emphasize that clinical trials are registered at the website clinicaltrials.gov. And you can find the clinical trials in metastatic gastric cancer on the website. You can also find the clinical trials on the websites in the East Asian countries. Currently, most key clinical trials which can change the standard of care are globalized and include patients both in the West and in the East. Thank you so much for your attention.